There is a decision many people over 60 make without fully realizing the cost of it. They are told a surgery is recommended. They hesitate. They say they would rather wait, rather manage it naturally, rather not take the risk. And in some cases, that hesitation is the most dangerous choice they make. Not the surgery, the waiting. I am Dr. Hiroshi Nakamura. I have spent more than 25 years working with older adults in internal medicine and geriatric care. I have sat across from hundreds of patients who came to me not because a condition had just appeared, but because a condition they had been ignoring for months or years had finally reached a point where the options were far fewer and far more dangerous than they would have been earlier. What I want to speak to you about today is something I see often, and it concerns me deeply. The assumption that after 60, surgery is inherently too risky, that the body is too fragile, that the right answer is almost always to avoid the operating room and simply live with whatever the condition is. That belief, while understandable, is not accurate, and in some situations it is actively harmful. I want to be very clear about something before we continue. No surgery is without risk. Every procedure carries the possibility of complications, and every decision must be made carefully in conversation with your personal physician, with full knowledge of your individual health circumstances. What I am not here to do is tell you surgery is always safe or always the right answer. What I'm here to do is help you understand that fear alone is not a medical reason to avoid a procedure. Because fear, when it drives the decision instead of evidence, can cost you something you cannot recover. There are 5 surgeries that many people over 60 fear more than they need to, and I want to walk through each one with you, quietly and carefully, so that if this is ever a conversation you need to have with your doctor, you are having it from a position of understanding rather than anxiety. The first is cataract surgery. Most people understand what a cataract is. The natural lens inside the eye gradually becomes clouded. Vision blurs, colors flatten. Driving at night becomes uncertain. Reading requires more and more effort. It happens slowly, which is part of the problem. Because it happens slowly, many people adjust to it without fully recognizing how much they have lost. What people do not always understand is what that gradual vision loss is actually doing to the rest of their health. When your vision becomes unreliable, you begin to move differently. You step more carefully. You reach for surfaces before you need to. You stop going certain places. You withdraw, sometimes without even naming it as withdrawal. And that reduction in movement, in confidence, in activity carries its own consequences. Falls increase, social isolation increases. And with both of those, the overall trajectory of health declines in ways that have nothing to do with the eye itself. Cataract surgery is one of the most frequently performed surgical procedures in the world. It typically takes less than 30 minutes. In most cases, it is performed under local anesthesia, meaning the patient is awake but comfortable and returns home the same day. The recovery period is short, and the results, when the procedure is appropriate and well-timed, can be genuinely transformative for independence and quality of life. The risk of serious complications is low. The risk of allowing vision to continue deteriorating, and of everything that follows from that, is often considerably higher. I want you to pay attention here, because this is the part that rarely gets named clearly. The fear people have about cataract surgery is usually the word surgery itself. But the question worth asking your doctor is not whether surgery sounds frightening. The question is, what happens over the next 2 or 3 years if this continues without treatment? Ask that question. Let the answer guide you. The second surgery many older adults fear more than necessary is hip or knee replacement. I remember a patient named Fumiko. She was 71 years old, a woman who had spent decades walking every morning, tending her garden, living actively. Over several years, her left knee had become increasingly painful. By the time I first saw her, she had stopped walking her morning route. She was moving through her home carefully, holding walls. She was afraid of falling and afraid of surgery in equal measure, so she had chosen neither treatment nor movement, and the effect was visible in everything. What Fumiko believed was that at her age, surgery was too dangerous, that her body would not recover, that she would be trading one set of problems for another. What I needed her to understand was that the life she was already living, sedentary, painful, increasingly isolated, was itself a significant health risk. Inactivity at her age affected her cardiovascular system. It affected her bone density. It affected her mental health. The immobility she had accepted as the safer path was quietly doing damage. After a thorough evaluation and honest conversation with her orthopedic surgeon, Fumiko had her knee replaced. Her recovery required effort and patience. But 9 months later, she was walking again. Not the same walk as before, but a walk. She told me she had forgotten what it felt like not to be in pain. Hip and knee replacement surgery is not minor. It requires preparation, rehabilitation, and realistic expectations. But for the right patient, one whose pain and mobility have been significantly affected and whose overall health can support the procedure, the outcome is often not just improved comfort, but improved longevity. Because movement is not optional when you're older, it is medicine. If you are currently managing joint pain by doing less and less, I would like to know, have you had a full conversation with an orthopedic specialist about whether a procedure might help? Write your experience in the comments. It may help someone reading there to feel less alone in that decision. The third surgery I want to discuss is hernia repair. A hernia occurs when tissue, often part of the intestine, pushes through a weakened area in the surrounding muscle or connective tissue. It is common. It is often not immediately painful, and because of that, many people ignore it for years. This is where the danger lies. Most planned hernia repairs are relatively straightforward procedures. When performed on a stable patient under controlled conditions, they carry a low rate of serious complications. But a hernia that is left unrepaired does not remain stable forever. In some cases, the herniated tissue becomes trapped, blood supply is cut off. The situation becomes an emergency requiring surgery under far more difficult and urgent conditions on a body that is already in crisis. The difference in risk between a planned hernia repair and an emergency repair is not small. The body handles scheduled, prepared surgery differently than it handles emergency intervention. When a surgeon operates on a patient who has been evaluated, optimized medically, and is as stable as possible, the outcome is reliably better than when surgery must happen immediately in the middle of a complication. If you have been aware of a hernia and have been choosing to wait, I am not suggesting you make any decision without speaking to your surgeon, but I am suggesting that waiting indefinitely is itself a choice, and it is worth understanding clearly what that choice may eventually require. The fourth procedure is gallbladder removal following repeated gallstone problems. Stay with me for a moment because this one is important and often misunderstood. Gallstones are extremely common in older adults. Many people have them and never experience symptoms. In those cases, watchful waiting is often entirely appropriate. But when gallstones begin causing repeated attacks, when they trigger significant pain, fever, or infection, the situation changes. What happens inside the body during a gallbladder attack is that the stones block the passage of bile, causing pressure pain, and in more serious cases, infection that can spread to the surrounding tissue, and in the worst circumstances, reach a state called sepsis, which is a life-threatening systemic response to infection. The pattern I see too often is a patient who has had 2 or 3 gallstone attacks, recovers from each one, and then decides that since they recovered, they do not need surgery. What they do not fully appreciate is that each attack carries a risk of becoming the more serious one, and the surgery that is a calm, planned procedure today can become an emergency procedure after a severe attack in the middle of the night. Planned laparoscopic gallbladder removal, when appropriate, is one of the most commonly performed abdominal procedures in adults over 60. Recovery is typically measured in days to a few weeks, not months. The risk of leaving a troubled gallbladder in place, when the pattern of attacks has already begun, is frequently higher than the risk of the planned procedure itself. The fifth surgery I want to speak to you about is pacemaker implantation. When a cardiologist recommends a pacemaker, the word procedure and the word heart in the same sentence can cause immediate alarm. I understand that, but I want you to understand what a pacemaker actually does and what placing one actually involves, because the fear many people have is not proportionate to the reality. A pacemaker is a small device implanted under the skin near the collarbone. It monitors the heart's rhythm and delivers a small electrical signal when needed to keep the heart beating at a safe and steady rate. It is used when the heart's natural electrical system is not functioning reliably, a condition that in older adults can cause fainting, extreme fatigue, or, if untreated, sudden cardiac events. The implantation procedure is typically performed under local anesthesia. Most patients go home within 1 to 2 days. The device does not require the heart to be stopped. It is not open heart surgery. It does not involve the major physical demand that other cardiac procedures require. What happens without a pacemaker when one is medically indicated is not neutral. A heart that is beating too slowly or erratically is not simply inconvenient. Over time and sometimes suddenly, it is dangerous. The fear of the device should never be allowed to grow larger than the risk of the condition it treats. This next part is something I want you to carry with you beyond this conversation. Aging does not mean that the answer to every proposed surgery is automatically no. It means asking better questions. It means understanding the full picture. It means knowing not just the risk of having a procedure, but the risk of not having it. The body does not become immune to the consequences of untreated conditions simply because a person is older and would prefer to avoid the operating room. In many cases, the opposite is true. Small problems that are manageable now can become large problems that are not. The most important conversation you can have is an honest one with your physician, where you ask clearly, what is the risk of this procedure and what is the risk of not doing it? What happens if we wait 6 months? A year? What does this condition look like if it progresses without treatment? And who is the right specialist to evaluate this specific situation? Those questions, asked calmly and early, give you the information you need to make a decision from understanding rather than fear. The body has a remarkable ability to recover even later in life when the conditions are right and when care is given at the right time. I have watched patients in their mid-70s go through planned procedures and return to activities they had given up years earlier. I have also watched patients who waited too long arrive at a point where the options were significantly fewer. You are not powerless in this. You are not simply at the mercy of whatever your body does. You have the ability to ask questions, to seek evaluation, to understand your options before a small problem becomes a crisis. That ability does not diminish with age. If anything, it matters more. If this conversation was useful to you, I would ask you to subscribe to this channel. I will continue sharing what I observe in practice, the things that rarely get said in a 12-minute appointment, so that you can make better decisions earlier. Please share this with someone in your life who may be avoiding a conversation with their doctor out of fear. That conversation, held early and honestly, may matter more than they realize.